bit more about, privatization is not appropriate in all circumstances, but it might be sometimes. And then this sentence is important. While the League recognizes the definition of core government services will vary by level of government and community values, services fundamental to the governance of a democratic society should not be privatized in their entirety. These services include the electoral process, the justice system, military, public safety, public health, education, transportation, environmental protection, and programs that protect and provide basic human needs. So from that sentence right there, one would say, well, public health is included and programs that protect provide basic human needs are included. So obviously healthcare is included. And as a matter of fact, if you look at our meeting basic human needs position earlier in the, is it earlier or later in the impact on issues, it's actually in the second section, not in the representative government, but in the social issues. You'll see that on the meeting basic human needs list, they include healthcare. So you would think that was covered, but it's not explicit. And when we, the Vermont, League of Women Voters of Vermont, sought to use the healthcare position first, and we're told to use the privatization position, we were told, well, except that it doesn't apply because healthcare is not included. And so that was why we embarked on this study. And then you'll see in here, these bullet points are all considerations the League thinks you should look at when you're making a decision about whether to transfer public services, assets, and functions to the private sector. So if something's already in the public sector, say you currently have, your public post office, your public library, maybe you have a public hospital. We have all private nonprofits in Vermont, but other states have different things. But before you would consider transferring it to the private sector, you want to look at these considerations. And in the second set of bullet points, they say these are the requirements that you want to be looking at. And they're actually a quite good list. The two problems that we found with this position, in addition to the not including the public good, but one is that it only addresses things going from the public to the private. It doesn't talk about what if it's something that's really essential and a private entity starts it and you want to deprivatize it, or if it has been public, it went to private without going through these criteria and considerations, and now you saying, yeah, it's not working, we want to bring it back. There's nothing in the position to say, oh, it's okay to deprivatize. Now, and to advocate for deprivatization, right? So if you look at the bullet point 1, 2, 3, 4, 5, 6, 7, 8. So the 8th bullet point down there actually says a provision and process to ensure the services or assets will be returned to the government if a contractor fails to perform. Well, that sounds like if you have accountability, if you have a process and a provision in place and they fail to perform, then you should be able to advocate to take them back to the government sector, the public sector, right? But for some reason or other, our staff at the national office said, no, that doesn't actually provide a basis. We don't have control over whether there is a provision in process. And even if there were one and they failed to perform, we still can't advocate on that. So we wanted to make it explicit, just say right out that we can advocate for deprivatization when things are not serving the public anymore. And so there was a deprivatization issue, there was the issue of not being a public good, and there was the issue of accountability and being explicit. And then a final thing that we've had in our study, we were thinking, well, even if it had started as being private, in the healthcare field, because it doesn't follow free market principles, there's too many barriers to actually fit into our free market system, the idea of a free market. And so we felt that there was sufficient evidence to decide that you should be able to advocate to have healthcare services be pulled into the public sector, even if they had not previously been in the public sector. And we did not have time or expertise to study other areas. We happened to have a couple of doctors on the committee and a lot of advocates who'd been advocating for healthcare for a long time, who were very familiar with the Medicare issues, with Medicare Advantage, and then the more recent, the ACO REACH program, privatizing Medicare. So that we had a lot of expertise around that, but we didn't have a lot of expertise around private prisons, for instance, or a number of other things. So although we did enough study to say, yes, if it was public and it was privatized, you should be able to pull it back, we didn't have enough to say, well, we're confident that it's always better in the public sector. So that was a different case. And then there's in the position, they also have just the history that this position was created in 2012. And a lot has happened since 2012. We had no idea in 2012 how this was going to escalate, about the private equity, for instance, getting involved in our public goods. So now I'd like to show you the Vermont Concurrence. And I wanted to show you this first because we have all these bullet points, and we are basically, and that phrase, if the contractor fails to perform. So here's our concurrence. So this is the position that we passed exactly the way we passed it, with only the blueprint is where we changed the words from League of Women Voters of Vermont to either saying League of Women Voters of the United States or just saying the League, and everything else is the same. And we had asked whether it would be possible to present a shorter version for the concurrence, because we were getting feedback that people thought, well, you shouldn't have all those bullet points in there and this and that. And we figured it would be an easier lift and, and easier to get it passed if we had shortened it. But when we were passing this position, we were looking at what Vermont wanted for our own purposes. And we felt that our league members don't actually know that much about the issue, the impact on issues, and they wouldn't necessarily know to go back and see what was in the privatization position, and they wouldn't necessarily know that there was a study to go and read what the criteria were for whether something could meet the free market principles. So we put some of that right in our meeting here, our position here. So the League of Women Voters of the United States believes that healthcare, like other programs that provide and protect basic human needs, should be considered a public good. Just want to make it really explicit. We would have been happy if they just stuck the word public good in that paragraph where they're in that sentence where they're listing them. I don't think that they are willing to do that. And nobody will show me the policy to say why they can't just do that. But anyway, the League believes that public funding, oversight, and delivery of essential healthcare services, including tests, So this list is basically in the healthcare position, right? But if people don't know how to access, the impact on issues, and go find the different positions. So it's right in there. Similarly, quality, transparency, accountability, and affordability are critically necessary for effective administration. Further, the League supports public oversight of all aspects of healthcare, from policymaking to administration to accountability, and public participation in policymaking and accountability as essential. And some of that is connected to the position we have on public participation. That we actually wrote this first knowing what we believed and what we had kind of heard over the decades of experience of one of our members. My experience is much more limited, but she felt very strongly that we should have that very explicitly, saying public participation in the policy making, not just like giving some input at a town meeting, but actually that when you give that input, that they actually look at all the input and factor that in when they're creating their policy. And accountability as essential. So that accountability that we refer to in the national position, we want to have it, we wanted to emphasize it here as well. The League believes the current private enterprise for-profit business model for providing healthcare is inappropriate for the common good or to meet the basic needs of the most vulnerable members of society. It's not working for most Americans, their providers, or their communities in the following ways. And I will share in advance that there are people who were opposed to the idea that the word current is in there. And I'm like, Okay, fine, take the word current out, but the national organization said we had to present it exactly the way we had passed it. They may have some flexibility about how they add it in, but we couldn't have flexibility for how we presented it for concurrence. So then here's the list of the following ways we were talking about. So private for-profit corporations have a fiduciary responsibility to their shareholders rather than to patients or public health. The league favors a system where fiduciary responsibility is to the patients. Any questions on that one? That sound understandable? Okay. Healthcare is not discretionary spending where consumers can choose what product or service, which brand, and how much to purchase. Patients do not have perfect information, which is one of the criteria you're supposed to have for a free market system. And they usually are not able to make decisions and seek care based on comparison shopping. The league favors a system that ensures that patients needing healthcare have those needs assessed based on standards of care offered equitably and constrained by public policy rather than by the patient's ability to pay. So if anybody has comments, go ahead and break in when I'm in between my bullet points, comments or questions or concerns.
Okay.
Lack of a profitable market for providers can create healthcare deserts in poor or low population areas. Does everybody know what a healthcare desert is?
Yes.
Okay. So it's a place where there are not healthcare facilities. They have a huge shortage and they have to travel long distances to get to healthcare. The league favors a system where all communities have access to quality basic healthcare because this will improve both individual and public health. Free market principles require that anyone who benefits from a service must pay for it, and anyone who does not pay for it should not benefit from it. The league favors a system where healthcare needs are met regardless of a patient's ability to pay because this will improve our longevity and general welfare. So I used to always use the example of tuberculosis, that you want anybody who has tuberculosis, you want them to get treatment because you don't want them giving it to everybody else. Okay. Now we have COVID. Okay. If somebody had COVID, you wanted them to be treated rather than passing it on to other people. So the fact that somebody who may not have money might not get the care actually harms the whole community. And then there's broader issues to look at. If somebody is a young person who has a long number of years ahead of them where they could be working, paying their taxes, contributing to society, and instead there's a reason they have a disability that they can't afford to pay for to deal with the medical problem, then not only are you not getting taxes from them from their working, but you're spending money because if they're indigent, they end up on Medicaid. So there's a number of reasons economically, because of the loss of taxes and because of the reduction in healthcare services if they have better health, but also because you have people who can then be working, teaching, all the different careers that we need to run our economy and run our society. Let's see here. People do not consume healthcare on a supply-demand curve. A person without a disease has no interest in purchasing treatment for that disease, even if it's free. If you don't have diabetes, you're not going to buy insulin. And if you do have diabetes, you're not going to buy more insulin because it's on sale or the price is good. Okay, you will buy less of it if it's higher and you don't have the money for it, but you're not going to buy more than you need for your condition. A person whose child's life depends upon a standard treatment should not have to forego their child's care because its purchase price is beyond their means. And as a society, we all want children to get the care that they need. And want them to get it at the time that they need it, not having it be delayed with more complications and all. In addition, patients cannot legally vary the amount of a prescribed product that they purchase based on price, nor would such variation typically serve their health. We touched on that a little bit. In addition, are there any questions about healthcare and free market principles? There are more than here, and they'll be in the report when we finally get that pulled together. But do you have questions about healthcare and the free market principles and why healthcare should generally not be a for-profit? Well, it should never be for-profit, and it should generally not be private.
No, really, I don't. So
I don't have any questions about that, but I don't I didn't see anything in this concurrence that I remember that was about the insurance industry.
So-
Did you think about that when you were writing this?
So we did think about that. And the thing is, the insurance industry is a private industry. So if you had a particular means that you wanted to address that, you could use this position for that because it's a private
Okay.
industry.
Okay.
But and the other thing that we did not specifically state in this is we did not discriminate between nonprofit. Let me think here. We did not discriminate between nonprofit and for-profit because we want them to go by the same criteria. There are many nonprofits who actually behave like for-profits. Sometimes it's because they are actually owned by for-profits. If you actually go back into,
Right.
Yeah.
Yeah.
So that's one reason. Another time they sometimes act like for-profits is because they actually have to compete with the for-profits. And if the for-profits are doing various things to try to cherry pick and lemon drop and keep their prices down, people won't buy the nonprofit if the prices are higher. So then they are not serving the public anyway. Now, and if they're gone, then the other companies could then boost the prices if they don't have the nonprofit to compete with them. So there's a number of reasons that nonprofits may behave like for-profits. So we still want them to go by those criteria in the national position. When you go through those steps, these are considerations about whether it's reasonable to be in the private versus the public domain.
Okay.
I did want to make one clarification, is that when we talk about private, we're not private ownership. We're not talking about like a private practice of a doctor or a group of doctors or a nutritionist that has put out her shingle or his shingle. Those are considered professional corporations. So if you have a business, even if you're a solo practitioner in medicine, or if you're a private lawyer, you often, or maybe usually, have done the legal stuff to be a corporation to keep it separate from your personal finances for tax and legal reasons and all. So those are called professional corporations. And we're not talking about those. When you have these laws across the country, I think there's 13 or more states that have corporate practice of medicine laws. And it's basically saying that corporations should not be involved in healthcare, and that it needs to be, if it's a corporation, if it's an organization that is providing the healthcare rather than just a single doctor, then it should be the board should be predominantly doctors, or whatever the healthcare professional is. And that they, it's normal that you're getting your salary out of the business expenses, but not profit of shareholders. Okay. So a professional corporation can just be the people who provide the care. And the corporations that are talking about in these bills against the corporate practice of medicine are talking about when an organization that has, the big wigs that make the administrative monies, they work in the administration and make the big salaries, they're not actually healthcare providers, and they are not contributing to the health of our population. They're, doing the movement of money to line different people's pockets with the money that should have been going to healthcare. So I'm going to go back to reading this here. We have a few more paragraphs. In addition, the League supports healthcare as a public good for fiscal reasons. And this is with the word current again, that some people are opposed to the fact that the word current is in there. Our current multi-payer, multi-layered system contains significant financial waste, including excessive administrative costs and misdirected marketing costs that create additional barriers to care. Anyway, so the next sentence is, this is the most important sentence for people who are looking at deprivatizing prisons, for instance, or medical transport, emergency medical transport, ambulances, whether they're looking at water or libraries. So this sentence, though, is therefore Where private entities fail to deliver, the league supports deprivatizing. And then the last sentence is bringing us back to, and we specifically took out the word healthcare because we wanted it to be more generalizable. In sum, the league opposes further privatization of needed healthcare and favors deprivatization of services and facilities that are currently owned, managed, or financed by for-profit corporations.